Hello, my name is Claire Oliver-DeHaven, and today I'm presenting a Level 4 case study of the low-impact lateral meniscus tear in a male high school football athlete during the COVID-19 pandemic. During this case, we were presented with a young male that had a low-impact contact injury that resulted in a complex injury much more commonly seen in high-impact contact with multiple directionalities. This case highlights the need to prioritize early onset of rehabilitation for post-surgical recovery and indicates a focus on compliance for all recovering individuals. This case study presented a 16-year-old male football athlete with no previous knee injuries, with lateral left knee pain along the joint line after an uncontrolled roll tackle drill was performed during practice. The patient identified the primary point tenderness along the lateral joint line, therefore the diagnosis led us to a lateral meniscus tear. The patient was immediately treated with ice and compression and referred to the team physician for confirmation through radiology. The team physician was able to confirm the left knee lateral meniscus tear through an MRI and indicated surgical intervention was necessary. An arthroscopic meniscal repair was performed on the expected bucket handle tear, which was identified on both the posterior and anterior horn of the meniscus, during which the dysvascular non-viable portions were resected and revealed a secondary horizontal tear of the posterior horn. This was also repaired during this arthroscopic surgery, and then healing was stimulated through perforation, rasping, and excoriation at the tear site. The postoperative instructions included a protective weight bearing for 4 weeks, followed by progressive weight bearing as tolerated. The initial goal was to achieve full range of motion and return to play in 6 to 8 weeks. However, the patient was then exposed to SARS-CoV-2 virus, requiring a quarantine for 10 days immediately postoperatively. This two-week regression from therapy then led to a 4-week regression in extension to his return to play. The patient returned to therapy 10 days after the post-op exposure and was immediately returned to his continuing range of motion practice, as well as increasing his quadriceps strength, balance, and proprioception. Focus then also turned to cardiovascular rehabilitation, along with minimal agility training as tolerated. The prolonged duration between surgery and initiating the rehabilitation process, however, dramatically decreased the patient's neuromuscular control, and the muscle tone was also lost. Thus, isolation of the muscle and retraining of the functional movements control were absolutely key in being able to return this athlete to play. This would not only allow for increased stamina, but also to avoid future re-injury.